Thank you. We'll now move on to Dr. Friedman.
I too want to thank you for the opportunity to share our experiences and also our patients' stories. I'm a neurologist at Rady Children's Hospital. I'm also a clinical professor of neurosciences and pediatrics at UCSD. We've heard already quite a bit about the rationale and the important goals of the moratorium in preventing fraud. And my purpose here today is to try to share with you some of the inadvertent human impact of these policies. Dr. Jones has already outlined for you an instance in which a Medi-Cal patient and family did not have access to potentially life-saving testing. And unfortunately, her experience is common. Every day, physicians, especially those who treat uncommon rare disorders, experience obstacles in obtaining necessary testing for their patients. Even when a Medi-Cal benefit is approved for this testing, there are often no Medi-Cal approved labs available to do the test. As a neurologist, I treat patients who have difficulty walking, including many patients with cerebral palsy. Some of these children, though thought to have cerebral palsy, instead may have a condition that by giving a medication which replaces a missing chemical in their body may provide dramatic improvement in their condition, allow them to walk normally, abandon wheelchairs, and may even be life-saving. When a child comes to my office and I may suspect this condition, many of the tests that are necessary to be done are not done at Medi-Cal approved labs. So as a physician, I'm faced with a conundrum. Do I just give up on testing and treat this patient as if they might have this condition, thus putting them at risk of side effects from the medication? Or alternatively, do I instead beat the bushes to try to find philanthropic funding or a research lab who might be able to support testing in the patient, define the diagnosis, and allow the appropriate care? The first option clearly places the child at risk. The second involves much time and effort, delays care, and may often not be successful. I face such obstacles to testing my Medi-Cal patients every week. Last fall, I'll give you an example of a child that came last fall, an 8-year-old girl that for purposes here I will call Emma, was brought to my office by her parents for imbalance and increased falls. I recommended several diagnostic tests, some of which were not available at Medi-Cal approved labs. And because of this, I investigated options for testing for the patient and tried to guide the family regarding alternative insurance plans that would cover the cost of the testing. Unfortunately, all of this sleuthing takes time that I, and it turns out Emma, also did not have, because while working for a solution, Emma developed uncontrolled seizures. She was placed in a medically induced coma, and though the coma has been lifted, 8 weeks later, she is still hospitalized at Rady right now. She is unable to talk, to communicate, to move, or to do any of her normal functions. While in the hospital, we were able to secure alternative funding to allow testing at a non-Medi-Cal approved lab. The test defined the diagnosis that I had previously suspected, and though treatment for this condition was started, Emma will remain severely impaired from this illness and may even die. Would it have made a difference had I been able to make the diagnosis and start therapy earlier? I will never know, but I will always wonder if perhaps I could have pushed the system faster and harder. What I do know is that the monetary cost of the ongoing care for this child already vastly exceeds the $600 cost of the undone test. The cost to Emma and her family, of course, is immeasurable. I am here today because I desperately want to avoid delayed testing from impacting another child the way it has Emma and her family. Medi-Cal children need testing and treatment in real time. Those with degenerative and life-threatening conditions cannot afford to wait. When no Medi-Cal approved lab exists, physicians should not have to choose for which patients to invest many hours of often fruitless efforts necessary to try to scrape together funding for specialized testing in unapproved labs. Similarly, hospitals should not need to solicit funds to cover the huge funding shortfall, even when a Medi-Cal approved labs are available. Doctors should be able to treat our Medi-Cal and non-Medi-Cal patients equally and provide them all with high-quality care. The situation I describe is not unique to Rady Children's Hospital, but affects Medi-Cal children throughout the state of California, as is evidenced by presence of several physicians from other California children's hospitals here in the audience. A story published last year in the San Francisco Chronicle highlights one of these physicians and the experience of a boy named Curtis. Similar to Dr. Jones' case, Curtis had a family history suggesting an inherited form of a heart disease that put him at risk of sudden cardiac death. Because no Medi-Cal laboratory existed to do the testing, doctors couldn't define the diagnosis and institute potentially life-saving therapy. All they could do was watch and wait and reduce his physical activity while they wondered whether he would develop this condition. There are many facets to limited access to life-saving testing for Medi-Cal children. Lifting the moratorium will not fix the problem, but is a critical first step to improve access. Other factors that contribute to the problem are beyond the scope of this hearing, but will need to be addressed even if the moratorium is lifted. These include the onerous, lengthy application process and financial disincentives, that bureaucratic hurdles that discourage the laboratories from even making the effort to apply. Dr. Jones and I are here as physicians to represent the patients we serve and to plead to be able to bring to Medi-Cal children the same level of high-quality care we provide our other patients. Without tests, we cannot make diagnoses, and without diagnoses, we can only provide second-class care. We don't want any more children or families to face situations similar to Curtis and Emma, and we look forward to working together to find a solution to improving healthcare access for this most vulnerable population. I thank you very much for your time.
Thank you. We'll move on to Mr. Randy Hugh.
Excuse me. Hi, my name is Randy Hugh. I'm with Counsel. I handle most of our health plan activities. And Counsel is a genomic technology company. And I think one of the big differentiations you're going to see with our laboratory versus any other laboratory that you compare is that our innovation is not in discovering new associations or developing new content, but our innovation is in leveraging technology. So very similar to an Amazon.com type of approach, where we're leveraging technology to provide better services and dramatically reduce costs. So as an example, our BRCA offering is a great example of reducing costs. Just hypothetically, if everyone that ordered BRCA tests just suddenly switched over to Counsel overnight, we would literally remove $400 million from the healthcare industry. Overnight, $400 million we would remove. And so just a little bit of background on Counsel. We're one of the largest genomic technology centers in the world. We've performed over 350,000 patient tests. And it was just 5 years ago when we had our first test that was publicly available in carrier screening. And so literally in the last 5 years, we've gone from 0 to now we screen for about 18% of all carrier screens that are performed in the United States. We estimate we're the third largest carrier screening company, right behind LabCorp and Quest. And with our 2015 forecast, we expect to be the #1 carrier screening company in the United States. And we're based here in South San Francisco. So I started about 4 years ago. And at that time, we had about 35 employees. Today, in just 5 years, we now have about 350 employees. And by the end of this year, we assume we're going to exit around 500 employees. We have about 14,000 physicians that utilize our test on a daily basis, and we're partnered with many healthcare systems across the United States, including Sutter Health right here in Sacramento. And in regards to commercial health plans, we're contracted. We have over 150 million lives under contract. So we're one of the few national laboratories to have in-network agreements with Cigna, Aetna, United Healthcare. We have in-network agreements with the majority of the Blues and many regional plans. And the reason why they contract with us is because we can deliver very high-quality assays and dramatically reduce costs. And so one of the questions that comes up, better, faster, cheaper, right? So what am I sacrificing? Am I sacrificing quality? And so the answer to that is we've invested quite a bit in software and automation. In fact, another big differentiation with our company is that we employ 30% of our companies are hardware, software, and automation engineers. And our laboratory is a $20 million R&D project. In fact, we were recently featured in Fast Company, and we've been named one of the top 10 companies in 2015 with innovation in robotics. And so essentially, we're the world's only fully automated laboratory in genomics. So what does that mean? It means it's 100% from cradle to grave, it's automated. So essentially, you take the blood tubes, you put them in the tray, you press go, and you let the robots take over. And what this does is it allows us to gain greater efficiency, higher throughput, faster turnaround times, and dramatically reduce costs. As well, and more importantly, it allows us to deliver a higher quality test. Because it's through automation, we're able to put a number of quality controls that without automation you could not do. As an example, we perform over 200,000 quality control checks every single week in our lab, and that is not humanly possible without this type of automation. Another innovation that we've developed recently is an online service that automates the process of notifying patients, delivering the results directly to the patients, and integrating patient education as well as on-demand genetic counseling. No other laboratory offers this type of service. And we feel it's extremely important, as vital as this type of information is, it's extremely important to have the subject matter experts to be able to interpret this type of information. And so we feel that's an extremely responsible way of delivering this type of information and test. We employ about 1% of all genetic counselors in the United States. And so our mission is to make this type of vital information accessible to everyone that is appropriate for, and especially those type of populations where they, in the past, have not been accessible to, right, because of cost. And so in regards to access, cost is dramatically reducing the cost is a big component of that. And as well as simplifying the process in order to get the appropriate subject matter expertise interpretation. And so we feel our mission coincides very well with DHCS's mission in stewarding the Medi-Cal program and offering the best healthcare services to all Californians. And so our experience with Medi-Cal is in 2011, we applied to enroll in the program. We were denied. We've approached DHCS in many occasions. We have been denied. And then we've sought help from Senator Jerry Hill's group. And then in 2013, when the Supreme Court had ruled in the Myriad case that genes cannot be patented, we then approached Medi-Cal again, or DHCS again, and we estimated that we could save approximately $11 million based on our BRCA offering. Our BRCA test is about 50% of what the current CMS reimbursement rates are today, and arguably is the best test in the market. And the response that we got from $11 million cost savings was that cost savings is not one of the exemption criteria in the laboratory moratorium. And I understand the spirit behind the moratorium is to reduce costs by preventing and controlling fraud. But we believe there are better ways to do that. And essentially what the moratorium has done is locked in all the laboratories that were the root cause of the fraudulent activities. And it's locked out potentially high quality clinical laboratories that can deliver better services and lower costs. And we all know that oligopolies, exclusive, provide zero incentive in regards to delivering innovation, delivering better services, and lowering costs. I would argue that all the providers that are within the enrolled Medi-Cal program, their primary focus is on how to maximize reimbursement rates within the current sandbox, right? And innovation, we also know that technology and innovation has drastically transformed every single industry. And innovation is driven by Moore's law, that every single 18 months to 2 years, that output doubles and then costs are reduced in half. I mean, this is the reason why my iPhone is 100 times better than my desktop computer was 10 years ago and only a fraction of the cost. And legacy companies will not innovate because they have a lot of legacy infrastructure, right? And that's a lot of weight to carry around. You cannot retrofit your legacy infrastructure with advanced technologies, otherwise you'll be cannibalizing your business. So our ask is, one, to use your position, to use your influence and decision-making power to be able to move the healthcare industry forward, right? we work with the largest payers, with Cigna, United Healthcare, Aetna. We work with them in these fraudulent activities. We work with them in identifying who the high cost and laboratories that are in using these fraudulent activities and using carrots and sticks to redirect them to a lower cost provider that's in network. You know, I understand there's a few states that have laws in place that make fee forgiveness programs illegal in that state, right? That also controls and prevents fraud. Our ask is also to open up the moratorium to allow high quality clinical laboratories that deliver value and can lower costs. And our ask is also to require that all laboratories that participate in the Medi-Cal program be required to share their data, right? We are right at the beginning of fulfilling the promise of personalized medicine through genomic sequencing. And the cost of sequencing is dropping extremely fast. But the biggest block and the biggest obstacle is the interpretation of the results. And it's only by labs sharing the data can we faster and more accurately give a more accurate result. And there is no clinical or ethical reason why a lab would keep their data proprietary, like a Myriad. The only reason someone would keep their data proprietary is because of business profits. Google has a very simple motto: don't do evil. Essentially meaning, do good, don't do harm. And so it is our opinion that the moratorium doesn't move the healthcare industry forward, it holds it back. We believe there are short-term and long-term financial consequences that impact the Medi-Cal program. And probably most importantly, it's a disservice to the Medi-Cal members. Thank you very much.
Thank you. We'll move on to the last speaker, Mr. Ackerman.
Mr. Chair and members, thank you very much for holding the hearing today. I'm going to speak very briefly on behalf of two providers impacted by the moratorium. I think the previous speakers have talked a lot about the innovation in laboratory medicine, and it's not just on the cutting edge of genomics, it's also just in routine laboratory medicine that laboratories that come into the program under the moratorium are basically set in a time warp where they can no longer add services that they were not providing when they were enrolled. It's kind of like looking at a surgeon and saying you're in the program as a surgeon, but you can't employ newer surgical techniques because the time you came and you were not doing them. So it's kind of fundamental to how clinical laboratories grow. We've worked with the department, California Society of Pathologists, which are physicians who direct clinical laboratories, have worked with the department over the years in crafting some of the exemptions that do exist, and we appreciate that. But they're very narrow, and they're very specific often to one provider or one particular instance. So it's time to reevaluate how that moratorium impacts laboratory participation. It is a daunting task, as other speakers have said. The department will cite, very high statistics of people being accepted once they apply, but you don't apply if you can't fit under the moratorium. So if you don't meet one of those narrow exceptions, there's no reason to apply because you will be denied. You do not meet one of the exceptions. So that's an issue. It's also curious that one of the exemptions is for large chain laboratories, and some of you know that several years ago there was a large settlement involving some of those large laboratories that were allegedly overcharging the Medi-Cal program. So they're into the program, but then other smaller laboratories are not allowed to compete and engage in the process. So it is rigorous. It is a deterrent to some providers applying. It is a heavily regulated area already. They're already licensed by Laboratory Field Services. They are CLIA certified. They are inspected by one of the accrediting bodies that the federal government recognizes. They depend upon referrals for those services. So if you're not a legitimate provider, chances are you're not going to be getting referrals from legitimate physicians. That's another issue. Sometimes the fraud that has occurred has involved bad physicians and bad laboratories. So that needs to be addressed. We would certainly agree that the department should focus on some red flags for relooking at laboratories or not letting them in. That could be a change of ownership, undisclosed ownership, et cetera. Those are all valid reasons for looking at laboratory participation. So it's time to review that and to allow laboratories to expand their testing options. In the area of durable medical equipment, the California Association of Medical Product Suppliers are an organization that represents durable medical equipment and medical supply providers. Back when this moratorium was created, there were real problems in the industry, and the department is absolutely right that there were problems that needed to be corrected. It hurts everyone, taxpayers, providers in the program, when there are bad providers and fraud is occurring. So we supported the department in that moratorium. Again, we've worked with them and had some expansion. If you're a custom rehab provider, meaning you're only doing specialized wheelchairs, if you're only doing portable home oxygen, you can be into the program. It's limited to certain counties, but a lot has changed since the moratorium was created and extended every 6 months. Medicare now requires all DME providers to be accredited by a recognized accrediting body. They have a series of 30 supplier standards that address some of the issues the department looks at in terms of hours of operation, disclosures of ownership, patient interaction, et cetera. It's time to look at those as to whether or not they may be sufficient to allow providers in that meet those standards. Most DME providers serve both Medicare and Medi-Cal patients, the nature of the services they provide, patients with chronic diseases and conditions that are not short-term events. And so therefore, they are heavily dependent upon Medicare and Medi-Cal. Medicare has a process, it works, it's faster, it's not as cumbersome. So anything can be done to look at how we could compare those two programs, reduce some of the hurdles would be welcome. It is only the fee-for-service side of Medi-Cal that limits participation, but as many of you know, Medi-Cal managed care plans may require the provider to be Medi-Cal enrolled before they can participate. So that is a barrier to entry. So appreciate it.
Thank you very much. Any questions from any of the members? No questions? Okay. I have a couple questions to Dr. Jones and Dr. Friedman. You know, with regard to the patients that you saw, were those patients that were fee-for-service, or were there Medi-Cal managed care patients? I don't know if you know that or if that information is available to you.
I can get that to you, but it's not off the top of my head. I can't tell you about my family.
Because I guess my question would be, would you still have the same problem if it was under a Medi-Cal managed care environment as well?
Sorry.
We would still have the same problem with regard to the laboratory not being Medi-Cal approved. Now, on a test case, I was able to find that there is a specific process for the Medi-Cal managed care that somehow people didn't seem to know about in our hospital, but one can apply to have that laboratory that is not Medi-Cal approved sign a letter of agreement with the, I think it's with the hospital, so that there is agreement for payment to take place. So there is a process for allowing that test to take place. The one test case that I did run through that process took 6 months for the first test that I wanted to do. So there is a process, but it is not a very manageable process.
Okay, thank you. Seeing no other questions from any of the members, let's go ahead. Oh, I'm sorry. Senator Penn.
Thank you. I just want to follow up with Senator Hernandez's question, because the children you presented sound like they were in CCS. Was that is that through Medi-Cal CCS? Because that would be fee-for-service.
Medi-Cal CCS would be fee-for-service, and I think the little girl that I talked about became CCS after we knew about her heart problem.
And I think, I don't know for sure, I think the little girl Emma is CCS. I don't know about the patient that was in the newspaper.
Okay, thank you. We'll go ahead and have item number 4, we'll respond to testimony by Department of Healthcare Services. We'll have them come up. And I'll have a couple questions as well.
Good afternoon.
Good afternoon. Go ahead.
Okay,
Would you like to
so
respond? And
I have a couple of
just
comments.
questions as well. Go ahead.
Sure. So a couple of comments. First of all, I'd like to address some of the things that I heard with regards to the lengthy process in terms of the application processing times. We do recognize that this is an area that we are trying to improve and to streamline our business processes. As such, we are launching a provider enrollment validation kind of application via some technology. So we believe that the number of days that it is going to take to process any kind of application is going to be streamlined in the near future. So that's to come. Also, in terms of, I just want to reiterate, that in terms of the clinical laboratories applications that have been provided to our department in the past year, 74% of them were approved and did meet moratorium exemption. The services, I think you highlighted, 70% of our beneficiaries, it's actually 72% of our beneficiaries now are in the managed care population, leaving about 28% in the fee-for-service. So lab services can be available under a managed care plan. Those services perhaps could be made available through the plans. Also, in terms of some of the innovation and the technology that you heard at the testimony, we do have our medical consultants within program that are constantly looking at medical journals. They're also looking at innovations in terms of technologies with lab services, and if appropriate, are coming to us in provider enrollment to make changes and to modify our moratoriums. So with that, Tanya, do you have anything further to add?
I think just to highlight that the moratorium does not impact managed care. And I also heard Mr. Ackerman speak about the managed care plans requiring enrollment in fee-for-service. That is not a Department of Healthcare Services imposed requirement, but rather a plan decision to make that a requirement of their contracting. So the moratorium does not impact managed care plans from contracting with as many labs as they wish. And that, again, 72% of our beneficiaries are enrolled there.
So, and if you could expand on exemption number 16 as well, which allows
Yes.
for enrollment of unique tests for those laboratories that are.
So exemption 16, which is a new exemption, which really did stem out of discussions with Rady's Hospital and California Children's Hospital Association, and also addresses Mr. Ackerman's issue regarding the lab that it set in a time warp, as he called it, back in 2001. So exemption 16, which was just implemented in October in the most recent moratorium, does allow a provider to apply when they have a unique service, even if it is not a Medi-Cal covered benefit. So in other words, as I've heard much of the testimony, is that there are services that may not be a covered benefit, and we don't know who they are, and providers can enroll if it's not a covered benefit. So the new exemption focuses on that very specific issue. So even if it's not currently a recognized covered Medi-Cal benefit, if there is a medical necessity, a lab offering that service can enroll to provide that service. So that, again, is a new exemption as of October of this year. I'd like to address specifically Mr. Ackerman's lab issue about the time warp. While indeed those providers that cannot expand if they've been enrolled after 2001, there are exemptions for them to expand their services. So if they meet an exemption under moratorium 11, 14, or 16, they can indeed expand their services. So there are other options. I think that's okay.
Okay, any questions for any of the members? Yes, Senator Pan.
Thank you. Several questions. First of all, how long has this moratorium been in place? Well, actually, there's multiple moratoriums. How long has each been in place?
There are 40 provider types, and there's 3 provider types that
Right,
are
so-
currently on moratorium. And so I would say that some have been implemented since 1999. To give you an example, the durable medical equipment moratorium was on statewide, but it's been modified over the years
And when
in
did that
that
start?
it's been reduced just to the 4 counties, so it is no longer statewide when it was first initiated. So some have been in place since 1999, 2000, 2001.
Okay,
The pharmacy 2002, and it holds 8 exemptions.
okay. So, for example, the lab, 1999, so it is now
The
20...
clinical lab since 2001.
2001.
With 16 exemptions.
Okay, so 2001 is now 2015. Laboratory science, at least as a physician, I know has advanced quite a bit. I'm sure there's also aside from that, I'm sure people have also started new labs. I mean, I can see having a moratorium for a period of time if you need time to go back and look at your regs and say, okay, we have a fraud situation, we need to. When do we expect the moratorium to end? I mean, you keep extending it every 6 months or something. When is the intention of the department to say, we have done our work to try to reduce fraud, put in the checks and balances in place and end the moratorium?
Right. So the moratorium is examined every 6 months, not only through provider enrollment, but as well as with our program staff. And we also, work with our counterpart, Department of Justice.
Is there an intention to end the moratorium eventually?
Well, there's been recent cases, in terms of whistleblower act under the False Claim Act that validate that government healthcare fraud continues in a big way. And so in May of 2011 and in August of 2011, there was action that was taken against 2 of the laboratories, which resulted in about payback of $500 million.
Okay. So that's not answering my question. And I'm not denying that fraud doesn't occur. And I'm not saying we shouldn't have checks and balances on fraud, but this seems to be a very blunt instrument because all it does is it's restricting people who can enter. It doesn't say anything about whether people are committing fraud inside or outside. I mean, I can see that in a situation where there's fraud, that until you can put your checks and balances in place, all right, let's create a moratorium, let's not bring in new people because we're not ready for that. But we've been doing this for 2001, it's now 2015, so we've been extending it every 6 months for a very long time, for over a decade. Is there some point in time where is that the only is that the main mechanism we're actually depending on to limit fraud? I would think that that's sort of not. That doesn't seem to make a lot of sense.
That's one component, but we also do work with our provider associations and those individual providers that are coming forward, and we have made several exemptions, to the moratorium over
But there's no
several
intention
years.
to actually end the moratorium and put in
At this point, I think the data is what is going to drive our decisions, so it's constantly being evaluated along with our program folks, in terms of whether or not we should be moving forward with lifting the moratoriums. We believe that it has been an effective tool, in terms of our ability to monitor those providers and to ensure that we have access to our beneficiaries, access to care.
I think there probably, a moratorium by its nature is limiting access. And so, as an instrument, I'm concerned about that. The other thing is you mentioned that, of course, you have the exemptions and mentioned 16 and some other ones. And while this only applies to fee-for-service, which is still 28%, it was mentioned in previous testimony, 6 months. You said you're going to streamline the process. How long do you think it's acceptable for someone to have to wait for an approval? 6 months, 1 month, 2 weeks, a day? How long should it take the department to actually approve an exemption? What is acceptable?
I would like to take that question back and actually do some research, in terms of,
Well, if you were waiting for a test that's going to decide what your diagnosis is, or your child, how long do you think is acceptable? Is 6 months too long?
To me, I think 6 months is too long to wait for an answer.
What about a month?
So I think a month is probably too long.
2 weeks?
I would say so.
Okay.
So this is something that I'll be able to take back and kind of look at what our processes are in order to, get the approval.
Okay, so it'd be helpful to set a goal for how long would be acceptable. Obviously, there's going to be processes in place to review, but hopefully, let's keep in mind from the care perspective and certainly again, I think it's important to have processes in place to root out fraud. Right? But we also have to be sure people have access to care. And also thinking about the amount of paperwork, what people have to do, whether it's the physicians or the families, how we can try to reduce that. And then I guess the other question is that I know that this only applies for fees for service, but oftentimes what the department does on the fee for service side, and we can simply say, well, the managed care company is on their own. But it does set the tone and expectation of the department. So I think that simply to say that this is not something that the managed care companies don't have to worry about, I'm not sure that's really the right approach. It comes back again to, we have, and I think it was stated in the previous testimony, do Medi-Cal patients deserve the same care as other patients? And I hope the answer is yes.
Absolutely.
And so, we should try to be sure that they have the same access to the care, which if managed care and also if one group of Medi-Cal patients should be able to access the same level of care as the other group of Medi-Cal patients. So simply saying that, well, the managed care, we don't have to worry about that, I think is, we really should be looking across the board. And actually, if there's going to be fraud, we don't want to see on the managed care side either, right?
Correct.
So if that's going to drive so much fraud to eliminate the moratorium, well, then let's see what they're doing on the other side and why, and if they're not having a problem, we should be able to learn from each other.
Okay.
Okay, thank you.
Senator Money.
Thank you, Mr. Chair and staff for organizing this. Thank you for being here today. Just to underscore some of my colleagues' concerns, it seems by definition the word moratorium implies temporary, and yet it seems that it's become the status quo over a decade. We're using a moratorium to achieve a more limited objective of controlling, eliminating fraud. It would seem to me that if you're going to use the word moratorium, included with it should be the stated objective of what are we emerging to with checks and balances to address the concerns. Instead, the default has been to work on this exemption system that, from some of the examples we've heard today, don't meet the needs of patients first and foremost in the physicians and medical care system organized to try to treat them. So I think it would be helpful for us in terms of a homework assignment to get a sense in each of these categories, what are the short and long-term objectives with some forecast of can those be achieved within the budget year, within 2 years, and in the interim of achieving those objectives that I think by definition should result in lifting a moratorium to a permanent status program. What can we do to accelerate the review of exemption requests when for families a 6-month or 1-year delay is, you've missed the boat, and potentially with life and death consequences. So it seems there needs to be a triage system within the exemption request review where certain cases get moved to the top. But I don't know if it's fair to any patient to say, you're not at the top of the list, but there may be, with medical input, a way to do some prioritization for use of those limited resources. And then finally, from some of the panel members as well, by closing the door to people that would like to participate, unless they qualify under narrow exemption categories, we are stifling a free market in innovation that can drive costs down. In whatever we're saving in fraud prevention, we might be saving 10 times as much through competitive marketplace forces, making available to California taxpayers a less expensive, or federal taxpayers, whatever the combination is. So anyway, just again, appreciate the opportunity of this oversight hearing to kind of put a spotlight on, but I think the status quo, while achieving some objectives, is woefully short. So what is the moratorium leading to, as opposed to just another moratorium? We just keep hitting the reset button. Thank you.
Thank you. Comments. I'm going to make a couple. I may derive a couple questions from it. And first of all, I appreciate the fact that you are looking at addressing the process it is for individuals to become Medi-Cal providers. But I'd like to first start to talk about the entire Medi-Cal system as a whole, because I believe that when you have a lengthy process, number one, it discourages anybody, whether it's a lab, Duro Medical Goods, providers, dentists, physicians, hospitals, et cetera. That, and also with poor Medi-Cal reimbursement rates, is another huge disincentive. yes, I know that under the Department of Managed Healthcare, where we have Medi-Cal managed care, we meet the minimum according to the state. But if you look at 1/3 of the population state of California is now in Medi-Cal, I think we need to do everything we possibly can to make sure that we get as many providers to take that segment of the population, which is a very vulnerable and very important segment of the population. So putting that into context, yes, I understand that fraud, we should not have fraud, and that we in government should do everything we can, and whether it's metrics or figuring out, what the outliers are, or database, or, pulling, samples. But I'm a little concerned about my two colleagues, what they said as far as the moratorium for being in over a decade. At what point do we not allow businesses that want to do business, that are doing it the correct way, and to make sure that they are part of the process? And I know the answer that we got from the department was, well, we're meeting the demand. Well, I can also argue that if you get even more individuals in there, maybe the cost will go down because there's more competition. Therefore, there's more access, and then there's more availability to the population. So I'd like to at least question and ask the department to look at the moratorium, or at least come back to this committee and say, do you see, what is your horizon, what is your timeline, and when do you plan to phase that out? And if not, why not? And to be able to answer, because there was a piece of legislation that was introduced last year to address a concern for a constituent, and if that's the case, then maybe we should look at a legislative approach to challenge the department to do so. I'm not saying that we're going to do it, but I think we have to have that information from the department. But a couple of things that came out of the last panel that struck me of interest was obviously the innovation. I really believe we have to look at innovation, and if there's entities out there that provide it, how do we make sure that we get them into the system? But the other one that really struck a chord with me was data sharing. And the reason why I think that's important, because if we're looking at a lot of rare conditions, with data sharing, if it's the state that's going to look at that, we can use that in a positive method. And that's the first time I think I've ever heard of that. And I would like to at least have my staff and maybe have you guys look at that, maybe as a viable option. So those are just some of the comments I had. By all means, yes, fraud is extremely important, but I would like to ask the department to maybe get back to me and tell me, do you see in any future of eliminating the moratorium? And if not, then what does the legislature have to do to address that? So with that, I don't see any other comments for this particular panel. We do have public comment. We're going to move on to, and by the way, I wanted to thank you for being here. And I'm looking forward to when Ms. Kent can come back in so I can give her a hard time.
Right. I do want to, just in closing, provide one remark that, when I started at the department, there was 7 million beneficiaries that we're serving today. We're pushing close to 12 million. Our budget is about $98 billion, and we do need to partner up with our physicians and providers, to provide the critical services, to those 12 million beneficiaries. So it does keep me up, in terms of thinking about ways that we can get new physicians enrolled into our system, and that's why we've launched our provider automation project, which, I know will make providers more easy to enroll in our program. So,
and I appreciate that. And I think that's something that's very, very important, because it drives my wife crazy when we have to do re-enrollment because it takes so long, because we're Medi-Cal providers, and it's just a very lengthy process.
Right.
Anyway, thank you very much. We're going to now move on to item number 5, public comment. We're done. Thank you.
Okay, thank you.
For holding this hearing. My name is Bryce Mendelson. I was born and raised in California. I'm a board-certified pediatrician. I'm a medical genetics fellow at UC San Francisco, but I'm speaking here today, as an individual physician and as a father. I'm holding here the cell phone I bought in 2001, which I think is an important year. This is an iPhone. I don't own stock in Apple. When I walk into the room of a child with Medi-Cal. This is many times what I have available to take care of them with. And no one here would use this technology to do their business anymore. And there's nothing factually that I can add to what's already been said, but what I want to say is I want to communicate the feeling of looking at a parent, knowing this is what you have to offer, when the kid in the room next door with private insurance gets this, and knowing that they love their kids as much as I love my kids and the people next door, but this is all I have to offer them. It's not fair. Thank you.
Hello, thank you. My name is Julianne Wojak. I'm a genetic counselor at the University of California, San Francisco, and I agree with everything that my colleagues have presented today, but there are a couple of, I think, misconceptions about genetics that I want to make sure everyone's aware of. One is that I think we think genetics are rare conditions that affect just a small percentage of the population. I specialize in cardiovascular genetics. These are inherited conditions that predispose to sudden death in otherwise perfectly healthy people. These are the healthy athletes that are competing that drop dead. These conditions are inherited, and they are variable, and they are very difficult to diagnose. Collectively, they may affect about 1 in 3 to 400 people in the population, so they're common. The other thing that I think is a huge misconception in genetics is that genetics is expensive and that genetic testing is so costly. In fact, it can be so cost effective. I have situations where we've had Medi-Cal insured members of a family. I had a branch of 7 individuals that I was able to reassure them and excuse them from ongoing, lifelong, specialized electrophysiology care for $350 that we had to use charity funding for. So these are a couple of misconceptions that I wanted to make sure everybody was aware of, and I applaud you for taking this issue on, and I fully support preventing fraud as a citizen who pays taxes as well, but there are different ways to save our money in the state. Thank you.
Bernadette Arellano from the California Children's Hospital Association. I just want to thank the chair and the members for allowing us to invite some of our expert witnesses to participate in the hearing today. And we would be very excited and supportive of the data sharing effort as that moves forward as well. We think that would be of tremendous public benefit. Thank you.
Seeing no other public comment, that'll conclude the business of the day, and we will adjourn. Thank you very much.